I'd like to start just by picking up on some of the points Deputy Ward made there, the excellent point in relation to the failure of mental health services to meet the challenge of dual diagnosis, which is really significant. And Dr. Nisey, you say there that if it is a primary diagnosis of mental health or psychiatric services would deal with it. If it's a primary diagnosis of addiction is the primary issue, the addiction services will deal with it. My personal experience in working with supporting people trying to access these services is that both services claim it is the primary issue is the other service, which is what leads to people falling between the cracks, and is exactly the problem of these services not working together. And I think really fundamentally illustrates the point of Mr. Farrelly that the mental health services aren't fit for purpose, and I thank Deputy Ward for raising this really important issue. I'd like to just pick up on something also Dr. Finnerty said. You spoke around the inconsistency around the country in relation to sort of the community services. I wonder if you could talk a bit more about that, particularly focusing on areas that have done it well, or you know, what can we learn from them? What can the other services that didn't do it well learn from the services that were doing it well? Or, you know, what contributed to those services' success amid the inconsistency?
Right. I think regional variation is a feature of the Irish mental health services. There is no uniform staffing, no uniform provision of service across the country. And I think COVID probably has highlighted this in some sense, where the provision of therapeutic services and programs by allied health professionals, by a small number of allied health professionals, then when they were unable to deal with anybody during the COVID crisis, that really set it up in sharp relief that there weren't enough services, that there wasn't enough resources in the community services. The difficulty with, if there aren't enough resources in the community services, then people will naturally gravitate towards the admission units. And then that leads to a difficulty on discharge then, because there's very little follow-up. So the problem of lack of access to community services is not just part of COVID, but COVID has actually made it worse. Some areas are particularly poorly staffed with allied health professionals and consultant psychiatrists, and this can be for a number of difficulties, for example, retention of staff, difficulty in recruiting staff, people not wanting to work in isolated areas. So it's multifactorial. Also, that where there have been a history or a tradition of intensive provision of service, the funding will stay there. It is more difficult for areas where there hasn't been a very high provision of inpatient services, for example, when the old asylums were open. It's difficult for them to actually get the funding to match other areas. So there's a wide variation in funding, and there's a wide variation in staffing resources across the country.
Thank you for that answer. Also, just a few questions in relation to the mental health tribunals. You were talking there earlier, Mr. Farrelly, in relation to how the mental health tribunals were able to continue. Were there any challenges? Did you have sufficient commission members or tribunal members to be able to deliver them? Was there any legislative challenges, you know, in terms of, say, meeting remotely or anything like that? Is there anything that we should be looking at in case we need to sort of, we face challenges of delivering the mental health tribunals again in the future that, you know, either positive lessons learned or things we would need to prevent?
Well,
Mistakes made now that we would need to prevent. Thank you.
Yeah, I think it's been a very positive experience because we're very clear that people shouldn't be deprived of their liberty unless they absolutely have to be and their rights are vindicated. So working with the department, with the people who sit in the tribunals, our staff led by my head of legal, I mean, I think that was a good piece of work. The lessons learned, actually, the biggest worry was people going into centres because people, a lot of people on our panels tend to be older, and there was worries around them themselves going in terms of secondary conditions, but it actually worked very well. We have to analyse it even more. The little bit of a worry in our head is just making sure that patients' rights are absolutely vindicated, you know, in terms of the solicitor representing them. Maybe looking at that, but we're all the time learning. But I have to say, in this instance, the HSE I think they performed well in this area.
Thanks very much.